Hello everyone, and welcome to the Demonstrating Implementation Excellence stream, the SNOMED CT Expo 2024. And thank you to FAST for sponsoring this stream. My name's Elaine Waller. I'm a senior terminologist at SNOMED International, and I'll be moderating today's sessions. Just a note that all questions will be answered at the conclusion of the presentation. For online attendees, please use the Q&A button to type your questions to the presenter. On-site attendees, please use the microphone which will be provided when you raise your hand to ask a question. I'm now pleased to introduce Kate Ebrill from FHIR, who will be presenting Sparked, Australia's National FHIR Accelerator, firing up adoption of SNOMED in Australia. Go ahead, Kate.
Thanks so much, Elaine. Hello, everyone. So lovely to be here in this beautiful country. I'm here to talk about Sparked. I am branded in it. So Sparked is Australia's National FHIR Accelerator. Who in the room is familiar with Argonaut or any of the FHIR accelerators in the US? Diego, Ruben. Who's familiar with the work that Korea's done around the Korean CDI and the Korean Core FHIR Implementation Guide? I can see some people in the room. So Sparked is doing something very similar in Australia. How do we develop those foundational standards that underpin interoperability within our country? So Sparked was established 12 months ago. It was funded through the Federal Department of Health and Aged Care, and it's being delivered in partnership with the Australian Digital Health Agency. And that's our national organisation who has responsibility for delivering the My Health record and is looking at the National Health Information Exchange for Australia. And it's also being delivered by CSIRO. So CSIRO is Australia's national science agency. We also operate the National Release Centre on behalf of the Australian Digital Health Agency. And we've been tasked with really building community in Australia, bringing everyone together to start to agree these foundational standards. Importantly, Sparked also has HL7 Australia as the affiliate responsible for the FHIR standards within our country. So we represent through CSIRO SNOMED in our country, and it's really bringing FHIR and SNOMED together to really look at these foundational standards to underpin our work. And it's really how do we accelerate the development of those standards in a way that brings all of the community together. And when we say community, it's about government, it's about industry, it's about clinicians, it's about healthcare organisations coming together and working also with consumers to make sure that we're developing standards that are about improving health outcomes for consumers, consumer-centred, ensuring they're fit for purpose for clinicians, making sure industry can implement them with little or no extra effort, and that these also support the government agenda. And by bringing all of those factors together, we can start to define those standards and start to enable the adoption of those standards. So Sparked isn't an application or a system. We're not building infrastructure in that way, but it literally is about building the community within Australia to start to define these standards. And standards are only as strong as the community. And I think Diego and Ruben would both say that FHIR is all about community. We know that Graham Greaves says it's about community, community, community. That's absolutely what we're doing in Australia. We're bringing as many of the organisations together as possible to help define and develop these standards. So we now have over 800 organisations registered as part of our community within Australia, representing all of our states and territories, our clinical colleges, and a large number of industry. And you can see some names there that are global industry partners, and it's really bringing everyone together. But what are we trying to do through Sparked? And one of the probably slightly different things about Sparked to some of the other accelerators are we really bringing those three core components together. What is that AU core data for interoperability, similar to the work that Korea is undertaking around the Korean core data for interoperability? How do we bring that together with defining the SNOMED CT ValueSets that are underpinning that data for interoperability? And how do we then support the development of the FHIR implementation guides? And that's coming all together through a large community and program governance to make sure all three components are being developed and delivered in sync with each other. One of the great things about FHIR and the work with SNOMED is it's not just about sitting in the room and having great discussions, but it's also about testing actively those standards and in ensuring that we're working with industry through developing, testing and piloting, standing up infrastructure to support testing, standing up terminology service to support testing and validation of the SNOMED content within the FHIR implementation guides, and also standing up reference infrastructure. In terms of our scope, where we started with AUCDI was really looking at what's the core of the core, what's that most important clinical information that if we get that right, we can actually underpin interoperability. And the other key use case we started with was looking at e-requesting. So how do we support e-requesting of pathology and diagnostic imaging? And with that, we're working very closely with our Royal Australian College of Pathologists and also the Royal Australian and New Zealand College of Radiologists to develop those standard catalogues of all the standard request terms that are in SNOMED to support the national e-request. Importantly, this is about bringing technology and clinicians together. So we've established clinical design groups where those clinical design groups are really looking at those clinical requirements, the use cases, how does it support workflow, and ensuring it's clinically fit for purpose. They throw that over the fence to the technical design group, where the technical design group can take those clinical requirements and actually start to build out the FHIR implementation guides and ensure that they can be implemented safely and at scale. And it's a real partnership and a feedback loop between those clinical and technical design groups, where we have over 400 people registered in each of these groups. And it's fantastic to see that every week we have over 70 people, Ruben joins these calls, sitting in these calls every week, debating and discussing. And so it's really brought understanding around those clinical data needs, together with really understanding how to implement terminology well, together with how do we implement this in the systems and start to exchange. What is AUCDI? What is this AUCDI? Very similar to the work that the US has done through the ONC, or I now should say ASTP, around the US CDI. Canada is doing similar work around a Canadian CDI, and it's been great. We've been able to have regular calls between the Canada team in CHIHI and ourselves to start to really share. And again, one of those values of being involved in something that's so global is we can actually share and leverage and learn from each other. And I'm excited to now see the Korean CDI, and we can start to understand what's happening in Korea too, and what we can learn from the processes here. So the AUCDI specifies what clinical information it is, and the AU Core is the FHIR implementation guide that specifies how. And in our AUCDI, we define that core clinical data, and we also define the SNOMED value sets that support that core clinical data. Because importantly, we want to focus around data entry as well. We want to improve the data quality within the systems. We just don't want to kind of push it around at the edges and have bad quality data just moving around faster. We're really trying to say, how do we improve that quality of data at the point of care? How do we ensure that systems are natively using SNOMED? So as someone enters a problem or a diagnosis into the record, that is actually a SNOMED CT coded problem or diagnosis. And similarly for our allergies, immunizations, medicines, where do we really want to get that data quality right and limit the amount of mapping within our system and really improve the data that's flowing through our system? In terms of scope drivers for defining it, where do you start with defining what is the core of the core, what that most important clinical information is? So we really looked at the health summary and what those key features of a core health summary were, what we needed to do around supporting chronic disease management, reason for encounter information, and how we would start to underpin decision support, and really looking at saying if we want to transfer clinical information from one practice to another, so one family care physician or general practitioner to another, what's that core data we want to exchange? What's that key information that sits as part of a discharge summary and aged care summary? And you start to see these repeatable elements around problem list, medicines, allergies and immunizations, and then we have maximal value sets that support this transfer. We also actually start with open air and we take in the open air archetypes. We bring in the clinical expertise that we have within our country and we start to build up AU-CDI. But AU-CDI is implementation agnostic. And then we take that over and we develop our FHIR implementation guides. So we're really taking the best of all of the excellent work that's happened through the open air community with large engagement of clinicians around clinical data models, but then start to constrain it for our particular use within Australia. It's also really important to come up with a set of data principles. Often in our country, our data has been designed by what the government needs for reporting. And so it's very much around population health or financial. It's not being designed by what the clinicians need at the point of care. So we said what we need to do is start to define what do clinicians need at the point of care within their record to start to support, importantly, deliver value back to the clinicians within their record. If we want to improve data quality, data is not, we need to make sure that the clinicians are entering the data for something that's of value for them, not of something that's of value to the government. We need to, and really I think one of the key things about the Sparked program is, yes, it's about standards development. It's actually a change and adoption program. This is about change management. This is about winning hearts and minds of the clinicians around why quality data is important. We don't have any government mandates that say people must enter data in this way or must provide these codes. So we had to say, how do we actually make this about change management, about adoption, about bringing the community together and saying, this will deliver value for me. If I enter into the diagnosis field or the medication field, SNOMED codes, that's going to give me a return within my record. That might provide better decision support, better functionality. It might mean that the clinician can enter data once within the record and that data can then be reused for smart forms or for reporting without any extra effort. So we really wanted to make sure this was driven by clinical needs first, not driven by national reporting needs, knowing that if we can do that, we will get better quality data that will enable us to report that data up throughout the system. So in terms of the scope of AU-CDI, it's the very clear basic information. I heard someone from the US say this week they called it PAMI or PAMPI, problems, adverse reactions, medications, procedures, and immunisation. Nobody can debate that if we actually had that structured and coded with SNOMED, that is the foundation of all information that we actually want to exchange from provider to provider. We delivered that in July and our scope was we had 6 months to do it and we said, let's do this quickly and let's get out for public comment something that nobody could argue with. Really tight, really scoped. And we had a large number of public submissions and they all said what we wanted to say. This is great, this is the first start, but here's the long backlog. And that's fantastic because we actually wanted people to want more rather than say they needed less and really create that momentum around, great, we want to get this structure coded, but actually let's start growing that. And it was really important that it was our community that fed that back to us, not us as government pushing that down to them. So in terms of where we're now expanding our scope beyond that is not surprisingly looking at the international patient summary and saying, how do we create an AU patient summary that takes the international patient summary and references AU core, and that really now starting to work with industry and clinicians across Australia to say, let's deliver that AU patient summary. And that AU patient summary is being delivered not for the international exchange use case, but like a number of countries, how do we use this to support transitions of care within our own country? And how do we now start to think of AU patient summary as the foundation set of data that accompanies all transitions of care. So when you do a discharge summary, when you do a referral, when someone may move from their home into a residential aged care facility, this is the clinical information that follows them and starts to become real-time updatable. We're also continuing our work around e-request and making sure we can have a repeatable process to service request in Australia so that there can be moving away from directed referrals to consumer mediated, where in the future the consumer can have a token on the phone with their e-request or their service request on their phone and turn up to any provider, any pathology provider that they wish, or any diagnostic imaging provider that they wish. I know I'm running out of time, so I'm just going to move quickly through. And importantly, as I say, this is about a community. So a lot of what we do is really, how do we create that sense of FOMO? We want people to come. We want people to actually be fighting to come to the events to discuss SNOMED. So, we love our events sell out. We don't charge for people to come, but, we end up with 130 people in the room having really great debates around what's important for them. And we like that other people are outside the room wanting to get in, because this is what it's about. We want people to be at the conversation and feel that it's important, that what they're doing is actually something that's of real value in actually working out what these clinical data standards are and what the interoperability standards are for the country. So 12 months in, we had 2 years funding. 12 months in, the government asked us to expand out around a patient summary, but also expand out around chronic disease management. So how can we start to define the data models and the SNOMED CT value sets that start to support care plans, start to support decision support within our country? One of the first pieces of work we've been doing in this space is looking and working with our College of General Practice and our National Aboriginal Community Controlled Health Organisations around the Aboriginal and Torres Strait Islander Health Check. It's a very comprehensive health assessment, and turning that in from being a relatively, yes, digital but dumb document into a smart form, so we can leverage FHIR questionnaires, we can leverage the SDC spec, we can leverage the fact that the systems have terminology within them, and start to pre-populate those comprehensive health assessments. And what it's enabling is that the clinicians will be able to have a richer conversation with the client around their health check. Rather than re-entering data within the form, the data will be able to be pre-populated from their existing EMR system using SNOMED into the health check form. And within that, we're embedding an Australian cardiovascular risk calculator. So again, the clinician doesn't have to re-enter the data. We're taking the latest calculator that's been developed by the Heart Foundation and embedding that within the form. So as they do the comprehensive health assessment, as the data is entered into the form and cholesterol levels and blood pressure problems, so problems if they have diabetes, SNOMED coded, all that data then actually can calculate the score automatically for the clinician. So they don't have to leave their system, go over to a website, calculate the score and enter back in. It can actually start to leverage the power that we have the SNOMED within the systems, the power that we're leveraging the work around FHIR within our questionnaires, that we're using the SDC spec to start to be able to generate this. And this is the real value as these standards start to come together. We are ticking off in terms of international patient summary. We'll start to do that in an iterative step as well. Not eat all the elephant at once and do all the work, but really start to align it with our work around AU Core and AU Core R2. So where we're focusing is, how do we start to look at pregnancy, social history and health behaviours, so tobacco, vaping, alcohol and other substances. And also starting to look at functional status and how do we record functional status in a more structured way. And so we really need to do a lot of work around our AU CDI to start to expand this out and build those SNOMED CT value sets that start to support functional status and these other elements, so we can bring these into a structured way within our health summary. Right now, some of these elements in the IPS spec, I understand, Ruben, are still largely in narrative form. So what we're really trying to do is lift this up to more structured form as well. And as I said, at the end of the day, if we can get this right for clinicians within their systems, structured and coded and delivered back to the clinicians, we can actually start to support this collect once and use many. We can start to leverage the exchange of data between healthcare providers, but importantly, we can start to aggregate this data up at a national level as well and start to improve that data quality. And this really can start to feed into service planning, funding, looking at national health indicators. And I think it's a goal for many of our countries to really start to build that learning healthcare system, where we start to have this data flowing through the system, we start to improve our evidence, and we can start to provide better decision support back at the point of care. So really, yes, AU CDI is about person care. What is that data that I need about me? What is that data that I need to exchange between providers? But we can start to then aggregate that data at a care organisation level. What do I need within my hospital? What do I need within my care facility? And importantly, start to leverage that up at the national level. So point of care documentation up to grouped, up to those core indicators. And this is really where we're starting to look within Australia around how does this support our primary healthcare networks? How does this support those national quality indicators? So on the this side of the board around designing data flow, this has been developed by our Australian Institute of Health and Welfare. This is what they're looking for the national primary care data asset around how do they start to collect that data at the national level. On the other side, on the left-hand side, is actually AUCDI. So we're working really closely with our Institute of Health and Welfare to say that now as they build their national minimum data sets for population health reporting, how do we turn it on its head? How do we start with saying, what do we need at the point of care first? What do we need for clinicians? Let's get that right, and let's that design and align that to those national minimum data sets for reporting. So it's no longer tail wagging dog, where the government is kind of saying, well, this is what I need at the national level, but turn it back around, what do we need at the clinical level? And then clinicians are more likely to ensure that that data is up to date, that data is quality, that data is meaningful, because they need to use it for themselves. We can do all the fun stuff nationally, as long as it's structured and as long as it's coded. We can then take that data and do whatever telling me to stop. We can, because it's my last slide, we can do what we need with that data then at that national level. So it's really changing the way that we're thinking about use of standards and terminology. So I believe that is my last slide, right on time. So thank you very much.
Hi. You said that the adoption of this initiative isn't sort of mandated by government.
No.
And I wanted to ask, you seem to have a lot of momentum, and how have you achieved that momentum? And what do you say to like skeptical clinicians and technologists?
Yeah, I think, as I said, this program is not a technology program. This is a change and adoption program. I think some of the key successes of it has been the bringing together of the government agencies, along with HL7 as a standards organisation, and along with kind of CSIRO as an independent broker in some way. One of the things that is very different about Sparked to the way that we have delivered our national programs in the past is this is the first time that we've done a truly open, transparent, collaborative program. So everyone gets a seat at the table. This is not closed groups, invite only. It is completely open. Everyone is at the table. It is absolutely bottom-up standards development process. And I think because it was the first time, everyone's like, we actually have an opportunity to be here to start to inform and start to actually drive something that's different. So we launched back in August 23 with a big launch event and invited a bunch of people to that launch event and made sure we had the right people in the room. So you need to start with your key champions. So we had key champions from our jurisdictions. We had key champions from industry and key champions from clinical organisations to actually make sure that we seeded the conversation, but it was seeded with this is about openness, this is about transparency, here's your chance to have a say. And we're very privileged that the government actually gave us 2 years to really trial a new approach to standards development. They probably took a really big leap of faith that you could bring the community together. We started with kind of 100 people in the room. As I said, there's now over 800 registered as part of the program. And we really said one of our things, we wanted to create a sense of FOMO. We wanted to create that it was the place to be, to have the conversation. And I think we've made sure that everything we do is open. So our website has everything. There is nothing that's hidden. Everything is on that website. Our progress reports are on that website. And so it's that really changing that dialogue that's about what you as a community are help identifying the priorities. You're at the table, you're setting the scope, you're identifying the priorities, you're making sure this is fit for purpose for you. Now, the fantastic thing is it creates a foundation that if the government chooses to enact policy enablers around regulation, they have confidence that a large number of people have been at the table having the conversation, and that a large number of people are participating in HL7 ballots and are responding. So it gives the government more confidence that they can take a certain direction, knowing that the industry and the clinical community will be on side. Also, I have to say we have a huge thanks to ONC and the US government, because the fact that they did put legislation and did mandate some of our industry is a big plays in the US industry. So we've been able to really take opportunity and benefit for that. And those leaders from those products from the global market are also co-chairs down in Australia. So they're at the table and they kind of know, well, this could come this way in Australia, our mandate. So we want to be here. So let's watch this space around what happens. But I would say you can drive change without mandate. And the benefit of that is, at the end of the day, when you do mandate, the people are still there doing it for the right reasons, which is because they know it delivers benefit to them and it delivers benefit to their patients.
Okay, got time for one more quick question.
Thank you. I guess we're all patients at some point generally, and you've mentioned that it's patient specific, or sorry, patient centric. And obviously, you know, even getting the clinical encounter sorted and meaningful for clinicians is a huge effort. But are there any specific mechanisms, or how do you ensure that it is patient centric at the end of the day?
Yeah, excellent question. And we need to do, I think it's something that's really challenging, because I think we all say consumer centered, but probably don't put the processes in place to make sure that that truly happens. We do have a number of excellent consumer advocates that are part of our program that actually come and participate actively in our workshops. And what we want to do is also work through our consumer advocacy groups within Australia to say, how do we get this message out more broadly? So it's not just those who are at the table who are actively engaged, but how do we get that out, and what social networks can we get that out to start to drive that conversation more broadly? And I think that's something that we all need to look at, how we do that really well within our countries and how we leverage that ability to truly get the consumer voice at the table.
Okay, thank you very much, Kate. And with that, we'll conclude the session of the